My name is Laureen, but my friends call me Lori. I am a wife, a mother of 4 children, ages 15 to 24, and soon to be grandma for the first time. I was diagnosed with stage 2 PBC at the age of 28, and I'm now 44 years old. Despite my most debilitating symptoms of itch and fatigue, I lead a busy life as an RN for the Federal Correctional System, working in community mental health, and as a Master of Nursing nurse practitioner student. The best way to describe the itch that I've experienced from PBC is an unrelenting needling sensation that gets worse when I'm stressed, hot, or if I've consumed food with too many preservatives or high in salt content. Antihistamines and lotions don't help, and coping with this complex symptom is incredibly frustrating. But no two PBC patients experience PBC in the same way, and the same is true for the treatment of complex symptoms of itch. What may work for one may not for another, which makes this an important topic for discussion. It gives me great pleasure to introduce Dr. Cynthia Levy to discuss the very important topic of itch and beyond.
Hi everyone, my pleasure to join you here. Oh my God, the room is really full. And I hope Gideon doesn't hear me, but this is a lot better than yesterday's meeting. So, Lauren said so many truths in that short statement there. So I hope you heard a lot of science in the preceding talks, beautiful talks. I learned a lot, and yes, I have questions that I jot down. We have tons of questions. But now let's see what we can do with what we have. Okay, let's see how we can help each other here. My disclosures. So this was given to me by the PBC Foundation. This is a survey they did for people suffering with PBC, over 1,000 patients, when they had to explain in one word how they felt. I'm sure this resonates with you, does it? It does, right? I see all the heads nodding. When they remove the most commonly cited words, then we have a lot more complex situation, but still the same symptoms bothering our patients. And this is not AI. This is, this is real world, okay? And this is the one I created using a small study we did actually with Ipsen. But the words are the same. So you're all dealing with the same problems, which we know we hear you. We hear you and we want to help. So I'm going to try and make this kind of practical and questions that I hear from my patients and how do we answer those. How common is itching in PBC? Am I different? How common? Well, you see, you're not different from the word clouds, but when you're in clinic and you're the only one and you don't have the luxury of having participated in a meeting like this, you feel very isolated and different. But the truth is, up to 70% of our patients with PBC report itching at some point in their journeys. Most of this will be mild itching, but in about a third of the patients, this can be moderate to severe. In our US registry, 37% had clinically significant itching based on that PBC-40 document instrument that Dr. Swain mentioned before. How do you know that your itching is due to PBC? That's another question. How am I supposed to know? One very specific characteristic is that there is no rash. So it's not like you have hives and a lot of bumps. The bumps can come later from scratching, but initially there is no rash. So that is one big difference. It's also intermittent, right? It's seasonal, it fluctuates, it's worse at night. You can see this picture, very striking with the scars from chronic scratching. And why? Why do we itch? Well, it's complex, it's multifactorial. We don't need to get into the nitty-gritty, but the bottom line is that there are several factors that play a role in here, and you will hear these names coming up in research studies, and in the medications that we offer to help are often targeting one of these. And that's why, as Lauren said, what works for one person may not work for another. It's a lot of trial and error when treating itching, unfortunately. So biosalts play a big role. It's cholestasis. Gideon mentioned how these bile acids leak from the damaged ducts, and they should not. be there, damaging the cholangiocytes, but that's what we see. So bile salts, they stimulate itch receptors. Guess where all these neurons will end up once they get activated by these skin receptors in the thalamus, that blue blob that Dr. Swan mentioned to you, and that's related to how you're going to respond to it, right? So there are plenty of itch receptors on the skin, and they respond to different substances. So some are bile acids, some are this lysophosphatidic acid, serotonin, endogenous opioids. Actually, the opioids work in different ways, and I like to give this example. I'm talking about itch. If you like to run, for instance, or exercise heavily, often you feel itchy after when you're jogging. And this is because you release your own endogenous opioids. So that causes itching. If you take Demerol, you go to the ER, you have pain, and they give you Demerol Dilaudid, you're going to itch. That's a side effect. Or they give you that for an endoscopy right before, and you feel that urge to scratch your nose. That's what it is. So opioids have been demonstrated that they're elevated in people with PBC, so that could be playing a role as well. So in the end, we have a number of factors. They all stimulate these different receptors. The stimuli goes through this neuron that ends up in the thalamus, and then we respond to that with the scratching behavior. Now, this is not witchcraft, or it's itchcraft, how we're going to evaluate it. There are formal ways of doing that. When we do clinical trials, if you help us and participate in studies, you're going to be asked to fill out a lot of these questionnaires. When we need that, because as was mentioned earlier, in medicine, we need objective ways to quantify and document what you're reporting us so that we can compare results, right, before and after. So we can use the visual analog scale. It's a simple 0 to 10 or 0 to 100, and you're asked to draw a line where it is that reflects the itching. And it's so interesting. If I ask my patient, so how bad is your itching? Oh, doc, it's okay. It's mild. All right, from 0 to 10, it's a 7. If you ask me, and the opposite happens too. Oh, it's a terrible itching. You know, I'm doing my best to handle, but it's really bad. I can't sleep at night. I'm itching. 0 to 10, 5. Well, you know, it doesn't always make sense, and that's why we need these multiple instruments to really get to the bottom of it. The 5D itch tells us about the duration, where in the body it is. Is it getting better, getting worse? What time of the day? Does it interfere with your sleep or not, etc.? What parts of the body? There are other questionnaires like PBC-40 will also have domains for symptoms, right? So we want to evaluate those objectively, at least when we're doing studies. However, in clinical practice, a simple do you itch or not and how bad is it would suffice to start. In reality, though, we don't do that. We physicians are really bad, clinicians in general, not just physicians. We're really bad in connecting. Sometimes because we don't have time, sometimes because we don't know the answer, so we better not get there, or it's too subjective. Let's focus on the alk-phos. You're doing great, as was mentioned before. So again, this is results from the Target PBC registry, where we compared the doctor's notes to what our patients filled out in their questionnaires. Those questionnaires that I showed you before, very objective, they didn't match, except when the itching was more severe. And again, that's easier to imagine because you're in clinic and you see the person scratching all the time. But for the milder or moderate itching, really there was no good correlation. And as expected, higher scores were associated with depression, anxiety, social isolation, and other things that I illustrate here. So sleep deprivation, social isolation, depression, fatigue, poor quality of life, loss of concentration, self-mutilation because you're scratching until you bleed. I see a few males in the room. I don't know if you are patients, if you're caregivers, but it's important to understand this in clinic, for instance. And I like to share my personal experience because maybe that's something that you have experienced. I have patients come to clinic and say, please, doctor, tell him that I cannot control this itch because the significant other is complaining that the patient doesn't stop throughout the night. So I'm glad that I can answer. I can help her just with that one sentence. But it's important to recognize it's out of control. We tried, there are a lot of medications that we're going to show, but this is not voluntary, right? It affects all the social relationships for that individual. People feel embarrassed. They don't want to go outside and go to the shopping mall and be scratching. People will think you have a contagious disease. So you become isolated, depressed. We see that. And here I put some quotes that I hear from patients that have been published in studies looking at this. I want to tear my skin off. It's relentless. As she mentioned, messes up with your mind. And what I always say, it's the worst. Nobody offered medication. Because we have options. They're not perfect, but we have options and we have more to come. In our target PBC registry, fewer than half of the patients were receiving treatment. How striking is that? And when prescribed, look at this, the most frequently prescribed medication, antihistaminics. What did you hear from Laureen? Doesn't work. It's not good enough. It's a little sedating, so maybe for the very mild itching, you can have a better night of sleep, but otherwise, it does not help. Cholestyramine came next. That's a bile acid resin. Rifampin, sertraline, or other medications were also used. So let's get to it. How do we treat the itching? The first step is this general advice. Again, we like to ask. We want to see how severe is the itching? How is it affecting your life? Do you want treatment? You may not want another medication if you can handle it. It's very individual, but the conversation has to be open here. So we recommend that you trim the nails so that you don't damage the skin. Avoid the hot showers because that usually triggers the itching. Avoid tight clothes, wool. Keep the skin moist. Vino bath, aloe vera. I've heard different home remedies from patients. Whatever works for you that will control the itching, that's good. Cold packs. And sometimes you need medication. Those are the drugs that we most commonly use. Cholestyramine, bile acid resin, so it binds those bile acids in the gut. And again, it helps for some patients for whom the bile acids are playing an important role. But if there's another mediator there causing the itching, this drug may not help very much. Plus, it has side effects, nausea, bloating. In some patients, that will cause diarrhea. In other patients, I have heard constipation. And there's the posology issue because it binds other medications in the gut. So a lot of drug-drug interactions, especially with the ursodiol, right? So you cannot take medications together with cholestyramine. You have to separate them. Rifampin, it's an antibiotic. It is also an FXR agonist and does help with itching a lot. I think it's underutilized. There's a small chance of causing liver toxicity. So many patients avoid that for this reason, and a lot of drug-drug interactions as well. Naltrexone is an opioid antagonist, and that's why it helps. It's also underutilized. I think it helps a lot of patients. Sertraline, it's an antidepressant, and sometimes if you offer this when we offer this to our patients, they say, but doctor, I'm not depressed. I don't need this. So I explained there are studies specifically looking at sertraline for itching. And it does improve. It helped 75% of the patients in that small study. So those are drugs that we commonly use. And one that is not included here, and I'm going to touch that on the future slides, is bezafibrate. There you go. So let's start with the fibrates. And this is a sensitive topic for me because we don't have this luxury in the United States. But bezafibrate was studied. This study is from Spain. Was an open label study, meaning we knew what the patients were getting. Everybody was getting the drug. And this was given for incomplete response to urso. It was not given to treat itching. But 48 patients were treated, and of these, 26 did have itching at baseline. So with a median VAS score of 8, so from 0 to 10. And then after treatment, you see how it dropped significantly. You see the spaghetti plots, the lines going down when you stop, and then when you give the drug, and when you stop it, the itching goes back up. So those were some earlier signs that the fibrates would work for itching, not just potentially for the disease. And eventually, this was the randomized control trial using fibrates specifically to treat itch. This was a study with 70 patients that included not only patients with PBC, but also with PSC or IgG4 disease. That's another biliary disease. And patients had to have itching that was rated as 5 or more out of 10. And 50% roughly of patients treated with this drug had more than 50% improvement, whereas only about 10 or 11% of patients, 13% in PBC, treated with placebo had that response. So we have here more objective evidence that the fibrates work for itching. What about other experimental therapies? There's a drug called butorphanol that I had a small case series of my patients in Miami in collaboration with our dermatologist. I'm so lucky he's an itch specialist. So we worked together to do this small series. Butorphanol is a nasal spray, and it is a kappa agonist, Mi antagonist. So it plays with the opioids. So it stimulates the one that blocks itching and inhibits the receptor that stimulates itching, that causes itching. So it changes how you perceive, how you respond to it. It doesn't change the stimulation in the skin. It doesn't, but it changes how you respond to that stimuli. And it was good in 5 out of 8 patients, caused some somnolence, nausea, and dizziness in a couple of them, but was well tolerated. So it's an experimental option. How about UV light therapy? So this is a session. The problem with this is that it takes a long time. It's 2 hours for each session, 3 times a week. So who has time for that nowadays, right? 12 to 60 sessions, mean of 8 weeks of treatment. But it worked. 70% of the patients had a significant response to this treatment. But again, it took months to get a response. It's an option. How about nasobiliary drainage? So what we have here is this is an invasive procedure. It's done through an ERCP. I don't know if you know what that is. That is an endoscopy where we go all the way to the duodenum, so the small bowel where the bile ducts empty out. And then we cannulate, we put a guide wire into the bile ducts. Then we put a tube, have you had a nasogastric tube in one of those feeding tubes? So we put it through the nose, all the way into the bile ducts, and then the bile drains out. So that's an invasive way to remove the bile acids, and it helped, but only for a short period of time, a couple of weeks, and also for how long are you going to carry around this bag? But it's proof of concept that removing these bile acids can potentially improve itching in at least a good subset of patients. Plasmapheresis is another mechanism. This is like a dialysis procedure. So it's invasive. You need to be hospitalized for 3 to 5 days on average. And it filters the blood. So assuming there is a pruritogenic, a substance that is causing the itching, even if we don't know exactly what that is, or more than one, but we filter it out. And patients who benefit actually can do well for 3 months on average, 3-4 months, then the itching starts back. So it's not a definitive treatment, and it's not for everybody. And then liver transplantation can be used. It's obviously like the last resource. And as we discussed yesterday, we're unable to give any extra points for itching. So it ends up that people who get transplant for itching already have advanced disease anyways and would need a transplant for another indication. But it's impressive. As soon as you wake up from your transplant, the itching is gone. And it's an amazing immediate response. Right, so in the real world, this is what we have. It's a stepwise approach, trial and error for a lot of patients. So we start with the very non-invasive, non-pharmacologic treatment, the bile acid binders and fibrates. Here you have bisafibrates, so it would be very reasonable to use it early on for itching. Or clinical trials. This between step 1 and 2 there, we have great clinical trials going on. I'm going to go through some of the data. So that's a good time to consider even before you go into 2nd or 3rd line attempts here. Right, so let's talk about novel therapies. We have odevixibat and maralixibat approved for pediatric conditions called PFIC and Alagille. Those are genetic diseases. And under evaluation, specifically for PBC, we have linerixibat, which is a bile acid transport inhibitor. I'm going to explain a little more about this in a moment. Volixibat, also an IBAT inhibitor that's being evaluated for both PBC and PSC. Difelikefalin, it affects the opioid pathway, and this study actually was interrupted, terminated. And then the MRGPRX4 antagonist, that's another itch receptor that we can block, and that's being evaluated both in PBC and PSC. So maralixibat is not currently under evaluation, but that was the first IBAT, so bioacid transporter inhibitor, that was evaluated in PBC a few years back. And this was a study where the dose was increased progressively throughout the trial. And then there were 3 different cohorts for doses compared to placebo. And what you see in panel A is that there was a decrease in the itch response from baseline to the end of the study at week 3. There was a significant improvement of about 25% in terms of the intensity of the itching. However, that was not different from the intensity of improvement that we saw in the placebo-treated patients. So that was initially discouraging, but then as we studied more about this process, we saw how there is a big placebo effect here, meaning just the fact that you're coming to a clinical trial center and taking a medication, that already makes us feel better, right? So that confounds the study and the results. So we started thinking that was a problem with study design and tried again with another drug called linerixibat. So this is to illustrate the enterohepatic circulation of bile acids. What is it? You produce and secrete bile acids from the liver through the bile ducts into the gut to help you with digestion and signaling, a lot of other metabolic processes. Then in the ileum, these bile acids are reabsorbed so they can be reutilized. About 95% of the bile acids are reabsorbed this way. It creates a cycle, circulation there of your bile acids. So we don't want to lose anything, right? We want to, we don't want to waste the bile acids. So what these medications do is they block that absorption in the ileum. So you start eliminating these bad bile acids. And this is one of the summary slides that I can present to you with results from the linerixibat study. There were 5 different doses studied, and I'm showing you 2 that had the most significant results. So the 40 milligrams twice a day and 90 milligrams twice a day. And you can see how the itching decreases rapidly from baseline and for the duration of the study. Then when you stop the drug, the itching goes back. The side effect of this medication is an increase in the number of bowel movements or sometimes diarrhea, because bile acids, you're not absorbing them, so they accumulate in the stool. They can cause some diarrhea. Despite that, it didn't lead to significant discontinuation from the study, so it's tolerable, very tolerable, and with impressive results. How about other drugs that are under evaluation? You heard briefly during Gideon's talk, I think, these names, right? FXR, PPAR, those are the receptors that are involved in bile acid homeostasis. One of them is the PPAR. Fibrates are PPARs, and seladelpar is a PPAR agonist. It's selective PPAR delta. That's a fancy term. But in this phase 2 study that was done, again, this was done for patients with PBC who were on USO and who were not responding completely to that medication. We noticed that in patients who had itching, there was a significant improvement. So my point is, even though the study was not designed to assess itching, it was so obvious we did see, especially with the 10 milligram dose, you can see again the lines, the red lines all coming down. And if you look at the bar graphs in the bottom, especially for the patients who started out with severe or very severe itching, most of them improved on drug. So that's very exciting, therapy to come. That medication also showed when we use the 5D itch, remember how in that instrument there was one domain assessing the impact of itching on sleep? The PBC-40 has the same. And in these clinical trials, you're asked to fill out a questionnaire. That's why we saw that for those taking seladelpar, and you can see, we show you bars for the 5 to 10 milligrams, which is a titration arm, or the ones receiving 10 milligrams. Let's focus on the 10 milligrams just to facilitate here. I don't have a pointer, right? Green is good. So you see BL for baseline after 1 year of therapy, all right? And the pink there and the dark brown or magenta, whatever that is bad. Is when the itching really interferes with the sleep. So that's bad. And you can see after 1 year, there is less of the red and brown and more of the green. That's the visual of what we're finding. So probably through improvement of itching, we're leading through improvement in sleep. We need a lot more information and investigation on that, but that's a very positive response. Let's turn to fatigue now. You heard a lot about the mechanisms of the fatigue and all the implications. As Dr. Swain mentioned, this is the most disabling symptom for our patients with PBC, impaired cognition or that brain fog, anxiety, depression, isolation, somnolence, autonomic dysfunction. All of those are consequences or are ways in which the fatigue manifests in your lives. And unfortunately, there is no pharmacologic treatment. That is not to say that there is nothing we can do. That's very different. But there is no drug that has been shown up until now to improve fatigue. I want to just very briefly mention to you about this drug called setanaxib. It's a whole different mechanism of action. It's not a PPAR or an FXR or a bioacid, but it has been shown in animal models to also have anti-inflammatory properties and to possibly reverse fibrosis or the scarring of the liver. So this study is being done for patients with PBC who have incomplete response to URSO, like all the other trials. And we also collected questionnaires as part of the trial. So in a post hoc, so not the main analysis of the study, but in a separate analysis, we saw that there was improvement in itching, improvement in fatigue in patients taking setanaxib. And that was more pronounced with the higher dose of 400 milligrams twice a day. This was measured through the PBC-40, and it's a clinically significant improvement. We can't fully explain that. Can't fully explain that, but it's something to be explored as a medication that could potentially help with the PBC and with the fatigue. All right, so that's why the management of fatigue is this windy road, because when we don't know the mechanisms that clearly, it's very hard to provide targeted therapy. We're working on identifying the mechanisms more clearly, but currently we need this listening, being empathetic, taking you through this journey. Fatigue is, even though it is real, there are MRI changes, there are instrument changes that we can objectively identify. In the day-to-day, it is non-specific, and there are other things that can cause fatigue. As was mentioned, but it's not totally wrong. We are busy. We all have other reasons. There are medications that can cause fatigue. Anemia causes fatigue. A poor night of sleep causes fatigue. Not the whole story, but it adds to it. Hypothyroidism, which is common in PBC patients actually, can cause fatigue. So identifying these other components and eliminating them can help. Treating the itching, giving a good night of sleep, exercising. So exercising has been shown to improve that peripheral component of fatigue that Dr. Swain mentioned. Decreases the acidosis and improves your recovery time. So it really helps with the fatigue. It's paradoxical. My patients tell me, "Doctor, I'm telling you I cannot get out of bed. And you're telling me I need to exercise." I know, but trust me, it will help after you go through that initial challenging time. Mindfulness, very powerful what our brain can do. Dr. Tandon will be talking to you later, and she has a beautiful program, which I have been referring patients to, that helps you, and I receive excellent feedback. Medications, clinical trials, we are waiting on that. So it's a composite, right? We have to work on all these things at the same time. Last but not the least, I just want to touch on the Zika symptoms because I think this is a lot more common than we see in text. So textbooks will tell you about 30%. I actually think my patients, more than half of the patients have dry eyes or dry mouth or both. So greedy, sandy feeling, irritation, itching in the eye, trouble with the light, tolerating light, blurry visions, those could all be manifestations of dry eyes. And then for dry mouth, that can lead to increased cavities. Actually, I had patients referred to me by the dentist because that's how they eventually found the PBC. It was such bad Zika syndrome. Difficulty swallowing, what we call dysphagia, change in the taste, and even infections because it changes the flora in the mouth, and there are more fungi like Candida growing that can be a result of the dry mouth. Esophagitis, that's inflammation of the esophagus. And the management for both dry eyes and dry mouth starts with prevention. So as we start recognizing the symptoms, then for the dry eyes, important to avoid windy outdoors, prolonged screen time, use glass or barrier methods. Then there are artificial tears that can be used, topical agents. Even your hepatologist is able to prescribe that. And when it gets to a certain point, we refer to ophthalmology to give other prescription medications, but Restasis is a cyclosporin drop, steroids, and there are others that can be tried. And in very refractory cases, even systemic, meaning oral immunosuppressants are needed for that. For dry mouth, there are a lot of things that we can do with over-the-counter products. So first, avoiding those substances that can dry your mouth even more, like coffee, alcohol, tobacco, cannabis, right? Medications for urinary incontinence, antidepressants, anticholinergics, those all have dry mouth as a side effect. So maybe we can swap the medications and that will have some benefit for you. Then we can use these over-the-counter products, artificial saliva. There are mouthwashes. So in the United States, it's called Biotene. I don't have stocks on it, but I do advertise because it helps a great subset of patients. One of them just recently taught me about the xylitol. It's called Xylimelt. So it's like a pellet that you put in the roof of your mouth and it stays through the night. It doesn't fall. So you don't choke on it. But that provides you more durable relief. And for the refractory cases, there are some oral medications that we can use, like pilocarpine or cevimeline, which can also have some other side effects. So we try to avoid that. But our colleagues in rheumatology can help us when it gets to this point. So instead of giving you just quotes of how you all feel when you're suffering from the itching, I want to give you this quote from a patient who was actually participating in a study, because this is what inspires me to be here, right? When you hear this powerful statement, I gained my life back. So when you have this relationship with a clinician, and you have the opportunity to try different therapies and to embark on that search, you will find something that will take care of your symptom. So I hope with this conference, not just my talk, but all of our talks here today, we want to empower you. And I hope that's what we are doing. As you learn and engage with us, you are empowered to seek treatment, to question your treating physician. Question not by confronting them, but question by showing that you know that you have options. You deserve an opportunity there. So feel empowered by this. And finally, I want to thank my team at the Shift Center in Miami. We're able to participate in all these studies, seek clinical trials too, because that's how we find these medications that are effective for you. So thank you everyone for listening.